Good afternoon, good evening, everybody. My name is Beate Schmidt. I'm Clinic Leader CT for Germany, Austria, and Switzerland. And I'm very happy to welcome all of you attending today's webinar, Cardiac Imaging with CT Revolution 8 centimeter detector coverage. Our speaker, Mr. Taha from Lüdenscheid Hospital, Germany, will share his insights from daily routine in coronary imaging and also gives tips and tricks for a successful cardiac exam. He will also provide first experience from his department with GE's deep learning image reconstruction true fidelity applied on coronary CTA. As Mr. Taha will introduce his institute during the lecture, I will not waste more time on introduction now. Please write all your questions in the Q&A section. You find it in the bottom of your screen. We will answer it at the end of the presentation as you will be muted during the lecture. If we will not have enough time for all your questions, we submit those questions to Mr. Taha for answering and attach it as a PDF file to the replay, which will be uploaded to our GE Cares platform together with this presentation. So let's begin now. Very welcome, Mr. Taha. The floor is yours.
Thank you, Mrs. Schmidt. As Ms. Schmidt said, my name is Taha. I'm a radiologist in Klinikum Lüdenscheid in Germany. And thank you all for joining us, and greetings to everybody around the world. And I would like to share our experience with cardiac imaging with our CT Revolution. So a brief introduction of our hospital, Klinikum Lüdenscheid. It was built in 1973. We have 28 departments, around 900 beds, around 1,800 personnel. From them is around 300 doctors, 310. And we are part of University of Bonn. We are an academic teaching hospital that belongs to University of Bonn. Our department, a radiology department, or the Department of Radiology and Interventional Radiology, we provide broad spectrum for in and out patients. We do around 80,000 examinations per year, from X-rays to interventions or CT and MRIs. For the cardiac imaging, we have around 550 cardiac MRIs per year and around 200 cardiac CTs per year. Since March 2018, we have installed our CTGE Revolution, and since then we do all our cardiac CTs with this machine. So our experience with the GE Revolution. Firstly, our standard protocol for cardiac CCTA. So just like every other CTs, we start with a scout, AP, and lateral. We do first the calcium scoring, and then the CCTA. Both would be in step and shoot. Our machine is has 8 centimeter detector, so we need 2 scans per examination, and both would be standard as prospective trigger gating. And normally the machine would have to skip 1 heartbeat between each scan. And almost bolus tracking in the aorta, we have the standard GE CCTA protocol, which have some software for quality to try to improve the quality of the examination, adaptive gating, smart arrhythmia, and auto gating. I will come later to it and explain and discuss them. kV assist, normally from 80 to 120 kV, and smart MA from 50 to 475, and we have a target noise index which would normally be set at 32. So that's standard CCTA examination. We have here the scout, here only AP, And normally we have 2 overlapping scans, each at 8 centimeters to cover the whole area of the heart and the coronaries. And we have the ECG gating, and we see the normal ECG, and normally a standard would be trigger at 57%, which correlate to end-diastole. And as we see here, the automatic gating does start at 57% at 1 beat, then we'll have to skip 1 beat, which the machine needs to move to the other location and start the next scan, and then the second scan also at 57%. With CCTA at 8 centimeters and almost on every CT, we have some challenges that we need to overcome to improve the quality and to have the best quality that we want to get. Some softwares that GE provides that help us to overcome these challenges would be, as we said, the arrhythmia, the smart arrhythmia management, which is targeted at detecting the extrasystoles or any abnormal heartbeat that occurs during scanning. So the machine would automatically detect if there is an extrasystole or abnormal heartbeat during the scan, and then would stop the scanning to be able to get a better results. So for example, here in this picture that we see, this red triangle correlates to an abnormal heartbeat that was triggered during the scan. So the machine stopped the scanning and then just waited, and then the scan in a normal heartbeat with the help of adaptive gating, which avoids the scan in the heartbeat directly after an abnormal heartbeat, which would normally be have less quality because the machine cannot exactly predict when would the end diastole be. So we just skip the next heartbeat and do the one next to it. And here in this example, we see the 2 heartbeats, the normal scan after that. This is an example from our hospital. Here we see a patient with paroxysmal extrasystole. So every now and then would come an extrasystole. The first scan was done at the normal heartbeat, and then the second scan was supposed to be around this time. The machine detected this extra heartbeat and then stopped the scan in this instance. The next heartbeat was abnormally long, and the end diastole would not be precisely predicted. So it also skipped this heartbeat, and then the next one was gated, and then the examination was done. Another software that is available is the auto gating, which help in what we call padding. So normally we would do the gating at 57%, but in an example like this patient who has a arrhythmia, and we cannot really predict when would be the end diastole, because one heartbeat would be abnormally long, one heartbeat would be abnormally short. So the machine would detect this arrhythmia and would do a longer examination, so we have better chance to catch, as we say, the end diastole. So here in this example, the machine, instead of only triggering at 57%, it started from 30 to 70%, roughly, and we would be able to look at all the images after the examination and choose the one that correlates to the end diastole. It was both, naturally, this would mean more dose for the patient, but it would be much better than having an examination that's non-diagnostic and then we'd have to repeat it. So it makes sense to do something like this in such an example. Some challenges that we would face in 8-centimeter detector, or any detector that's less than 16 centimeter or 12 maybe, that can cover the whole heart in one scan. So in this example, we see here a step artifact that comes between the 2 scans, and the IBR or intelligent boundary registration technique would be able to detect this artifact, the step artifact, and correct it so that one, by reporting, can better see the artery and can better detect any abnormalities in the artery. One might say this is only possible for the small artifacts that are caused by the heartbeats and not if the patients breathe in or breathe out between both scans. Here we see actually the patient was able to hold his breath. The sternum, the skin don't have any artifacts, and the artifacts are only in the heart itself, which can be corrected. But if it's in the breathing artifact, then it's not possible. Another challenge is the motion artifact, which occur because the heart beats and we cannot, sometimes there's some motion artifact in the arteries itself, and we can use what is called from GE snapshot freeze, which looks at the heart and the different phases that were imaged, and then correct the motion artifacts. So in this example here, we see in the right coronary artery, there's relatively big motion artifact, which here one cannot really identify where the vessel wall, how big is the caliber of the vessel. And after the snapshot freeze, we can clearly see the vessel, the wall. We can clearly identify if there's any pathology in this vessel. Here's the same examination, the same patients, also the artifact, which only in another picture. Also here after the SSF or snapshot freeze, the motion artifacts are corrected and we can clearly identify the vessel. That's a reconstruction from the examination. And here we see the oblique or curved images from the vessel. And we see here the wall is not sharp at all. One cannot identify where the vessel wall, the caliber of the vessel is not clearly identified. If there's any pathology in this part of the vessel, it's really hard to detect. And after the IPR, one can clearly see the vessel wall. Also, the small vessels are much better delineated. And if there's anything here, one can clearly identify it, or at least much better identify. So our standard protocol, we start with patient preparation. So we review the clinical indication, what's the history of the patients, what's his symptoms and signs, why we do the examination. And then prior to the examination, prior to the appointment, the patient would be told to take an oral beta blocker, and he would take it 2 hours prior to the examination for frequency control. We would speak with the patient, discuss the examination, how it would be done, the procedures. We discuss the respiratory command, the contrast medium, what would the patient feel, what we need from him to do. It helps a lot that the patient knows exactly what's coming, so that he would be relaxed as much as possible. No stress, because if the patient got surprised when the contrast media started flowing in his veins or something similar, that would probably lead to some abnormal heartbeats, or maybe would lead to abnormal heartbeats, which we don't want. So it's really essential that the patient knows exactly what's coming and how it would be done. It really helps in getting better quality. And then the patient would get in our machine, our examination table. We put the ECG. We want, when possible, a heart rate of less than 60 beats per minute. And even after the oral beta blocker, we would give IV beta blocker until we reach our target heart rate of less than 60. And we'd give metoprolol until the maximum dose is reached, or at least until we reach our target heart rate. And then directly prior to starting the examination, we give 2 puffs of nitroglycerin to dilate the vessel vasodilatation for the coronary arteries, so we can better see the vessel calibers and the wall. Then firstly, we do the calcium scoring. After the scans are done, we do visual quality control. If are all coronary arteries in the examination. Is everything, did the patient follow the procedure, follow the breathing commands? Do we need to repeat anything? Is everything okay? And then we do plan the CCTA. We have contrast media protocol, which involves 90% 60 milliliter, which are injected at 4.5 milliliter per second, and then followed by a tracker of 50 milliliter, 20%, which we found that it's better than only saline, for us at least, so we can better see the right side of the heart, the right ventricle, the right atrium, the pulmonary arteries, so we don't miss any big thrombus in the right ventricle, pulmonary embolism maybe, or anything in the right side of the heart. And 20% is more than enough to have just little bit of contrast in the right side of the heart, which is enough to detect something big, but not too much that would make artifacts or make anything that the main reason we are doing the study, the coronary arteries. Then we do bolus tracking, and we have our region of interest in the ascending aorta. We have a target density of 120 Hounsfield unit, and as said, we have with KV assist, smart MA, and then our noise index of 32. Here's an example from our machine. We have the ECG, we can also see the ACG, and here we have our region of interest, and we see the bolus tracking until it's triggered when it is more than 120 Hounsfield, and then the examination will be done. The machine gives automatically the breathing command and then start the 2 scans. After it's finished, we do the visual quality control. We review everything. If any problem that needs to be repeated in the examination, we do review of the multi-phase reconstruction if needed. Normally the 75% is more than enough, but if there's some artifacts in the 75%, we might need to reconstruct in multi-phase and see which phase we would see. We'd better see the coronary arteries. And then we do the snapshot freeze if needed, if there are motion artifacts, accordingly, according to the best phase that we found. And then the examination of the picture will be sent automatically to our AV server, Advantage Workstation server. We use the Cardiac IQ Express program, which have the automatic coronary analysis protocol that automatically detects the coronary arteries, the aorta, and just marks each coronary artery. And then we just review if vessel detection is correct. If most of the time it's correct, but if needed, sometimes it will detect a wrong artery or detect the artery with the wrong name. We might need to do the IBR, the intelligent boundary registration, if needed, if there's a significant step artifact in the examination. And then we start with reporting and evaluating each vessel. So I have some examples from our hospital or our clinic. This here was a 60-year-old female patient with a high-risk profile. She was a smoker, diabetes, had currently no anginal symptoms, but had some dyspnea, which is why it was low-risk patient, relatively low-risk patient, and we did a CCTA to just exclude coronary artery disease. Here we see regular heartbeats, around 50 beats per minute. It was normally triggered at 75% as we needed. We had a total CCTA doses length product from 22.71 and an effective dose of 0.32 millisievert, which is very low comparing. And this patient, she didn't have coronary artery disease, but we had for me, it was a very interesting anomaly here in this 3D recons. we see here the right coronary artery, the normal right coronary artery, from which comes the posterior interventricular and the posterior lateral branch, but the left side of the coronary arteries, they are all come from the right coronary. Here we see the left anterior descending, which wraps around from outside the pulmonary artery, and then goes in the interventricular groove, and the circumflex artery, which goes between the aorta and the pulmonary artery, gives rise to the diagonal arteries, and then wraps around again and goes in its normal atrioventricular groove. Here's, maybe we can better see how it is. Gives rise to the diagonal arteries and then wrap back around and go in the interventricular groove. Is the same examination and maximum intensity projection. We see here the circumflex artery, which have a relatively acute curve and goes back between the aorta, the pulmonary artery, goes here over the left ventricle, give rise to, we cannot see it here, but it gives rise to all the diagonal arteries, and then go back in the circumflex. Here is also a reconstruction for all the vessels of this interesting anomaly. Case number 2 is a 45-year-old male patient. He had 10 years ago an occluder for an atrial septal defect. He had since then recurrent episodes of atrial fibrillation, and the patient was scheduled for pulmonary vein isolation for this atrial fibrillation. And of course, with the occluder in the atrium, it was not that easy to go from the right side to the left side for the vein isolation. And we needed this CT examination to plan with the cardiologist needed this to plan for the transseptal puncture. We decided to do it in retrospective gating to be better able to see the atria, the ventricles, and also the heart valves. We had a total dose of around 130 milligrade dosage lens product and an estimated effective dose around 1.8 millisievert, which is okay for such an instance. We decided to do it in venous phase, and here so we can get a homogeneous contrast all around the heart. Here we see the occluder in the forehof and the atrial septum. And with planning, we were able to decide that here would be the best place for the transseptal puncture for the cardiologist, and they did just that, and it was a successful pulmonary vein isolation. Another case is a 43-year-old male patient with hypertension. He had chest pain, but non-anginal symptoms, which is not reproducible, and was not really atypical angina. Normal CT examination here had close to our target heart rate of 60, which was around 63, 66. Total dose of around less than half millisievert. And he had, just wanted to show here this plaque, and that's with the left anterior descending. And here we see this vulnerable, high risk, low attenuation part of the plaque and the calcification on the outside, which is, as you know, this vulnerable plaque, and which was scheduled for coronary angiography to do it and stem this part. And then we had a 78-year-old male patient with known coronary artery disease. He had a coronary artery bypass for the left anterior descending, the right coronary artery, and the obtuse marginal artery. And he had currently no symptoms, but was just follow-up to see if all the bypass grafts were okay, if everything is okay. Is there any stenotic segments, or everything is okay? Here we see, naturally, we had to do 4 scans with the 8 centimeter to be able to get the origin of the left internal mammary artery, the lima. And we can see the gating at each of the 4 scans. We had a total effective dose of around 2.7. And just want to show you, this patient had no relevant stenotic segments. All the grafts were okay, all the vessels, after considering the bypasses, were all in okay. And just to show you this case, and here we see the multiplanars for the left internal mammary here, and we see when it comes in the left anterior descending, here is the vein bypass to the obtuse marginal here, and then it goes to the obtuse marginal, and this was for the right coronary artery, and here is where it merges with the right coronary artery. And as I said, for this patient, everything was okay. So as Mrs. Schmidt talked about, we had some experience with the true fidelity or deep learning image reconstruction, which is a new technique from GE that's used to reconstruct the images instead of the iterative reconstruction. So here, just brief, we have the artificial intelligence, which incorporate human intelligence to machine learning, which we would tell the machine to do something, and we start teaching the machine how to do it, and then deep learning, which uses these neural networks so that the machine would be able to improve itself over and over, and we get normally better results, which is a much more complicated. Probably there's a lot of technical people who can speak about this much better than me, but just brief intro. So our true fidelity, it uses this algorithm, deep learning algorithms. Brief history. So at first we had the filtered back projection, which had a lot of image noise, and we had to do high dose to be able to get less or better signal to noise ratio, and had a lot of noise in low dose CTs. Then came the iterative reconstruction, which was able to get better results with low dose CT and also better results with normal doses. But it had the problem that the higher we go, the more plasticky looking examinations. Sometimes it looks artificial. Most people didn't like the really high iterative reconstruction. We said that looks paintbrushed, blurry, or botchy. And although we were able to reduce the dose and have less noise, but the image texture was not as wished for. And then we have the true fidelity or the deep learning algorithm, which can have low dose, high IQ, and natural texture of the examinations. Here we see the example. This is the true fidelity reconstructions, which have the benefits of doing low signal to noise ratio, even with thin slices, relatively fast. We can improve IQ, natural texture, not plasticky like or not botchy like the iterative reconstruction, and all of this with a relatively low dose. Brief for what's true fidelity. So we aim at reducing the noise and having better examinations while maintaining the contrast, maintaining edge, maintaining the normal anatomy and pathology that we find. It would not make any sense to have a really nice picture, but one that we cannot depend on detecting the pathology in the examination, and also no plastic looking image like with really high iterative reconstructions. I have here a few examples from our practice. So here, this was a coronary angio. Here is the examination, the standard examination was iterative reconstruction. This was done at 70%. we see here relatively good images. And then here we have this with true fidelity at medium and true fidelity at high. And we can clearly see the true fidelity reconstruction have less noise than the iterative reconstruction. One can better delineate the vessels. There's less artifacts from the calcification here in this vessel. The signal to noise ratio, just visually, we measured it, of course, but just visually, it's clearly better than the normal iterative reconstruction. Another example is here in an abdominal CT. We see here a small hypodense lesion in the liver, and this is reconstructed normally with the iterative reconstruction, and here was high. This was with a high true fidelity. And here we can see the same, much less noise in the image in the true fidelity part, and much better delineation of the lesion in the liver. And this would be even more helpful in a smaller lesions, or when we want to detect the infiltration, or where exactly that the lesion begins and ends. Another application would be in the low dose CT. This was an ultra low dose CT for just detecting a ureteric stone. And here we see the stone in the vesico-urethral junction, and comparing with the true fidelity reconstruction, we see much less noise in the image. The detection of the wall of the urinary bladder is much, much better in the true fidelity images. The blurring artifacts from the stone itself is much less in the true fidelity images. And this is not only helpful in the stone itself or in this area itself, but also if there's any other pathology in the examination, if something that's not previously known in the liver, in adrenals, in the kidney itself, one would be much more confident, would much easily detect these pathologies with such images as compared to what we used to from the ultra low dose images in stone imagings. So how can we benefit from such reconstructions in the coronary angiogram? So as said, we can clearly better delineate here. Also, this is with a normal iterative reconstruction here with the true fidelity at high. Here we see the vessel is relatively not sharp in comparison to the examination here. Here we can much better delineate the vessel wall. If there's any small pathology in the vessel wall, what would be more confident of the pathology in such images as compared to this one? The really small vessels here are much better delineated in comparison to the other one. Here also in the left anterior descending is the same. Another example would be here with this heavily calcified left anterior descending artery. As said, the blurring artifacts from the calcification is much less pronounced in the true fidelity images. One can better see where the calcification begins and ends. If there is low attenuation plaque parts, then one would be able to see it better in the true fidelity images. The image noise is much less. One can see the vessel caliber exactly, and one can have better chance to accurately measure the stenotic segment in the vessel. Here's another example with a heavily calcified left anterior descending, and we see here the blurring from the calcification. The vessel wall is not really, one can see it, but it's not clearly identified, especially when one compares it with the same examination, but with the other reconstruction with true fidelity. What we did with this for the coronary angio, so we had for, when we had the GE Revolution CT, this was about 3 years ago, we did a small study to see the quality and the dose from our examination. We had 50 patients. We did, for all of them, coronary CT angio with our GE CT. And we studied all the patients. We, like the American Heart Association, we looked at each examination and we gave a score to each segment of the coronary arteries, a score from 1, which means clear delineation of structures, wall, lumen, plaque, with no relevant artifacts, 3 being non-diagnostic segment, and 2 being not 1 or 3. And we gave a score from 1 to 3 to each segment of the coronary arteries. And we measured the effective dose, estimated effective dose for each examination. We had a mean effective dose of 1.01 millisievert. And of all the 50 examinations, 0 of them, we had a mean of 1.39 for all the segments combined. And 0 of the 50 examinations were at the end qualified or said to be non-diagnostic, and only 16 out of the 750 segments were found non-diagnostic. And after we got the true fidelity, we wanted to compare the results between a normal coronary CT angio or CT angio with iterative reconstruction and compare it with the true fidelity. And also we wanted to examine the possibility to even reduce the dose from the coronary CT angio even further. So what we did is we started collecting patients. We changed our standard noise index from 32 to 37 to have, one would say the quality would be a little bit less, but we would then reconstruct it with the true fidelity. And then we examine and compare the results with the old study and see how much down we were able to go with the dose. And also we did the same for the coronary segments, and we would not only compare it with the old one, but we compared the same examination, the reconstructions with a 0 or the iterative reconstruction from the EVE at 70%, and then compared with true fidelity at medium and at high, and then compare the mean from this current or the actual examinations with the historical data that we had. We still not finished with our study. We are still collecting some more patients and examining the data that we collected, but it shows promising results. The quality of the images are at par, if not better than the previous examinations, but we were able also, it's not nearly finished. We didn't have the same number. We didn't have the required number of examination yet. But the preliminary results shows really good dose reduction. We had in the previous study a mean dose of 1.01 millisievert, and in the current one with the dose reduction and reconstruction with true fidelity, we had a mean dose of 0.62 millisievert. We had the median in the old study at 0.75, and now it's at 0.39. Here we see in the current examinations the distribution of the dose in comparison to the body mass index, and we see that almost all patients under body mass index under 30, they had an effective dose of less than 0.5 millisievert, and only a handful of patients here, for example, that was because of high arrhythmia, probably, I don't know each dot of them. And most of the patients were either due to a high body mass index or due to high arrhythmia. And here we see the distribution from the current study and the previous study, and we see also that here most the examination stay under 0.5 millisievert, and in comparison to the previous examination, a previous study that were more distributed along the axis, and here we can say we goes all the way up to 1.5 and 2 millisievert, and here only a handful of people go over 1 millisievert. So, in conclusion, an 8 centimeter detector, especially at CT-GE revolution, is more than capable of consistently producing high quality images for the coronary CT angiogram. And we just need the right planning protocol, the planning with patient preparation, the right protocol for our needs, and with the right software and the right use of software, most, if not all, challenges can be overcome, and we can consistently get diagnostic and really high quality images, and also while maintaining a low dose and not just doing the dose all the way up. A possible disadvantage of the 8 centimeter detector would be the step artifact that comes between the two scans, which would be can be corrected with the IBR algorithm. Also, I need to say again, this can happen that the patient would breathe in or breathe out between the two scans. Unfortunately, when something like this happens, we cannot correct it, or the software cannot correct this, but it's rarely that something like this happens. Most of the time, the step artifacts that we see are because of the heart beats and can be easily corrected. Possible disadvantages of the 8 centimeter would be, obviously the lower price tag in comparison to a larger detector. And also, one might be able to adapt better to a larger volume, for example, a triple rule out or bypass CT examination. So we don't have to use the whole, for example, with the 16 centimeter detector, we'd have to use the whole 32. Here with the 8 centimeter. If it's enough, we can go a little bit lower, and we can reduce the dose a good bit. True fidelity can really help further improve the image quality, and our early observation, our experience for the last couple of months shows really good potential from the true fidelity to improve image quality in coronary CT angiogram and also in all other aspects of CT, and also show good potential of reducing the dose from CT angio and everything else. And thank you very much for listening.
Thank you, Mr. Taha, for your great presentation and your wonderful insights in coronary imaging with 8 centimeter detector. So I think we have time for a few questions. There are some questions in the chat and also in a Q&A session. So let's start with the first ones in the chat. One is asking, do you use auto voice breathing instructions for coronary CTA?
Yes, we do use the automatic. We have the bolus tracking, and then the machine uses the automatic breathing command, which we have measured it and we have adjusted our contrast media protocol accordingly. The machine takes about 7 seconds from the triggering from the bolus tracking until the examination starts, and we adjusted our contrast media protocol to this 7 seconds, which is much better than giving it manually, because this way we know for sure we have consistent results, and we don't need to depend on someone taking longer or less or anything.
Okay. So next is, can you please explain smart grep? I think you mentioned it already. The word is bolus tracking, right?
Yeah, The monitoring phase is just bolus tracking. We do the region of interest in the ascending aorta, and the CT, the machine do just one examination, or it's just a small examination in just a couple of millimeters, and to see this region of interest, what's the Hounsfield unit in this region. And as soon as the contrast media comes in the aorta, in the ascending aorta, then the Hounsfield unit would be increased. And as soon as it goes more than 120 Hounsfield unit, then the machine automatically starts give the breathing command and then start doing the examination.
Yeah. So if the heartbeat is too high, do you recommend do it at systolic phase or not to do it because of radiation, contrast media for kidney?
It depends on the question, what we want to answer. So at some instance, for example, in the acute phase, if someone is coming in an acute coronary syndrome, or we want to do an examination for the aorta itself, when we have suspicion of aortic dissection or something, we also always do it with ECG gating. In this instance, one would do the examination anyway, even if the heart rate is high, because the benefits of having a triggered examination to an untriggered examination outweighs the small artifacts that might come from a really high heartbeat. But if there's a patient with, for example, low risk for coronary artery disease, and the heart rate is really high, in this way, we might consider postponing the examination and looking further why the heart rate. And by really high, I'm saying like 100 beats per minute or 90 beats per minute. If it's only like a little bit higher than we want, maybe at 70 or something, we still do it normally in diastole. If it goes in the 90s or 100s, then according to why we do the examination in the first place, we might consider just doing it. And the machine in this instance, when it's really high, normally would do the auto gating, would normally come in, do the examination from systole, from end systole to end diastole, and we have both, and we can look at both with a little bit more dose. Or if it's something that can wait, we might consider just waiting and first clear why does the patient have a really high heart rate.
Yeah, so the scanner widens the acquisition window for you automatically. Yeah. So another question is, what is the solution if the heart rate has a consistent variation between the two scan groups?
If I understand this correctly, if just between the two scan groups, there was, for any reason, the common abnormal heartbeat, if I understand this correctly. As we talked about the smart arrhythmia management, if the scan was done during a systole, if the machine detected an extra beat or an extra systole, it would stop the acquisition and just wait for 1 or 2 heartbeats. If the machine detected that the second examination was still done in diastole, and we still have the same phase at the first scan, then it would be okay. I think I have something to show here. Just 1 second.
Yeah, you had one example on that.
Yeah, I had one with the, exactly here. So for example, this patient, he had this paroxysmal extrasystole, and we started the first scan was in a normal heartbeat, gated at 75%. The machine didn't scan in this time here because of the abnormal heartbeat, stopped because this was also a relatively long heartbeat, and then did the gating in the second heartbeat. And although here, the machine also, we can see it with this line here, the machine detected the extrasystole here, but still had the 75%, the end-diastole. So it did the examination anyway, and after the reconstruction and after everything, we reviewed it, it was completely fine, and we were able to get good results from the examination.
Okay. So another question is, can you explain the monitoring procedure for patients before or after the examination? How long do you monitor in the department after following the metoprolol? Are they monitored on arrival after having taken beta blocker?
We don't necessarily monitor the patients. It depends also if we had to give a really high dose, or we just gave or the patient just took the oral beta blocker. We monitor all our patients, all our outpatients for at least half an hour to 1 hour, not only, even if they didn't take metoprolol, for the contrast media, just to make sure that there's no contrast media reaction. And from metoprolol, it's really short acting, and just the couple of minutes after the examination, after giving the metoprolol to do the examination, sometimes it's 5, sometimes it's maximum 10 minutes, is normally more than enough to see if there's any reaction happened. And also, we still have the patient in our department at least half an hour after the examination if anything happened. We don't, as I said, we don't necessarily monitor with ECG or something, but they are under our eyes if anything happened.
Okay, okay. So there is one question related to the nitro administration. Does the use of MCG risk giving a false negative result, or does it highlight stenosis better?
No, actually, we found that it highlights the stenosis because when the vessel is a little bit vasodilated, we can better appreciate the plaques. We can better appreciate the small calcifications or the small low attenuation parts of the plaque. We can appreciate better the changes in the caliber from the stenotic segment to the normal segment. From our experience, from most of the studies around the world, we found that it really helps to give the nitroglycerine to be able to better see the stenotic segments. And yeah.
Okay, thank you. So one is asking, do you have experience with TAVI? If so, can you tell what protocol you are using?
For the time being, we don't do a lot of TAVIs. Yeah, we still have a protocol, but we don't do it a lot. Our normal standard protocol would be just triggered ECG, triggered with ECG gated examination of the ascending aorta, and then followed by just a spiral scan of the whole aorta to the femoral arteries for the planning of the TAVI, and just the triggered, the ECG gated part would be only on the aortic root and the ascending aorta to see the aortic valve and really do the right measurements in this part, and the rest would be just a normal spiral scan.
Yeah, for the vessel measurements.
Yeah.
Okay, thank you. So one asks, does True Fidelity help reduce step artifacts?
Sorry, step?
Step artifacts.
Oh.
Normally, True Fidelity is not designed.
It's not designed for such things, for step artifacts. The step artifacts, if they came from the heartbeats, the heart motion, we can correct it 99% of the time with just the IBR algorithm, the intelligent boundary registration. If the step artifact came from the breathing of the patient between scans or during the scans, from my experience, nothing can really correct that. And True Fidelity doesn't really help with that thing. It's also not meant for such artifacts.
Yeah. So I think we have time for 2 more questions before we have to close the session. what about cardiac perfusion? Are you also doing it?
Also, we are not doing it, but we are planning, hopefully, not very far from now, to try to do it. It has a lot of challenges to do the perfusion with 8 centimeter, but it is in our plan that sometime in the future, not the far future, but in the near future, we try to do it and look at our results. If we are able to consistently get good results, it's possible and it's doable, but has a lot of challenges. But for the time being, we don't do it, but we are planning to try it in the foreseen future.
Yeah. So last question, do you have many misregistrations between the two scan groups?
Misregistration, as I said, just different phases misregistered, or probably, if I understand this correctly, no, not really, not that much. It's sometimes, yes, we see that it's misregistered and there's a large step between the two scans, or maybe there's large artifacts in one scan and absolutely no artifacts in the other, which would come mostly because one didn't really start in the actual end-diastolic phase. But most of the time, with good preparation, and if we were able to achieve our target heart rate and the patient followed the procedure as we wished, no stress, patients don't really need to take a really deep breath, because that hinders that they stay at the same level, and sometimes you would have to breathe out before the examination is finished. So if everything was followed right, most of the time, no, we don't get that many false registration. We get it with some patients when there are really high heart rate or with extrasystole, with arrhythmias, and yeah, but most of the time, no.
Okay. So I think we're gonna close the session. Thank you so much, Mr. Taha, for your great presentation.
Thank you.
Thanks to the audience for participating. And if you have more questions, please don't hesitate to contact us through your GE representative or directly to GE Cares. Yeah. Thank you very much.
Everybody.
And have a nice evening. Bye.
Bye-bye.